So in the previous video, right, we talked about the SA node, we talked about sick sinus syndrome. So what would it look like if I had a problem at the SA node? And now we just kind of talked about AV blocks, talking about what would happen if I had a block here at the AV node. And one thing I just want to kind of bring home here is when we're talking about, what's the difference between a third-degree AV block and sick sinus syndrome. So we already said with a third-degree AV block, you have complete disassociation between the atria and the ventricles, right? Your intervals between P waves will be the same, and your intervals between your QRSs will also be the same. Okay, so there's going to be no change in those intervals. They're just going to be at different rates. Okay, sick sinus syndrome, remember the difference between this and that. In sick sinus syndrome, you can also have this kind of junctional escape rhythm that we just talked about. But in sick sinus syndrome, the way this will typically present is first you'll see a delayed P wave. So you'll see a delayed P wave initially. So what we're talking about is, right, so you have your P wave, QRS, T wave, and you have P wave, QRS, T wave. And we're just going to pretend that my drawing is all fine there. And then we have this delay here where we don't have anything going on. Then we conduct a P wave, QRS, T wave. And then what happens is if we were to keep going, we just have a sinus arrest and we don't have any P wave. And so what happens is the AV node then starts to take over and says, okay, I'm going to take it from here. And then we get a QRS and a T wave. So that's the difference. So you have a delayed P wave first, which is what happened here. That's the delayed P wave. And then we have a sinus arrest where the SA node just doesn't conduct at all. And that's what happened here. That's the sinus arrest. And then this conducted on its own without a P wave. Okay, so that's sick sinus syndrome. That's how you differentiate these two. So you can see that your P to P intervals here are not going to be normal. Okay, whereas with the third degree AV block, they are normal. And the same thing is true for your R to R intervals. Those are not going to be the same, right? They're going to be different, right? Because you had a delayed P wave before this one can conduct, and then you didn't have any P wave here, and so the AV node had to take over and have a junctional escape rhythm. And so that's the difference. So these intervals are not going to be the same in sick sinus syndrome, but they will be the same in a third degree AV block. So that's how you differentiate the two. In both of them, typically the patient will be bradycardic, okay, because a lot of this is dependent on these junctional escape rhythms I just told you about that are going to be conducted from the AV node. We know that the pacing of the AV node is like 45 to 50 beats per minute. So you're not going to have these patients usually tachycardic. They're going to be bradycardic for all the reasons we just mentioned, right? If you understand the rules of the game, a lot of this stuff actually makes a lot of sense. Okay, let's start talking about the right bundle branch block. And now we're going to kind of move down and we're going to see what happens in a right bundle branch block. Now, usually what we're talking about here is if I were to block, right, if I were to block this bundle for whatever reason, how would I get the right side of the heart to contract? Well, the way that would work is I would send my signal from the SA node down through the AV node, and it would only conduct on the left side, right? And then that signal through gap junctions would eventually get to the right ventricle, but it would take a little bit longer because this route is blocked. So it can only get there initially through the left bundle branches and then eventually through gap junctions to the right. Because of that, because it's going to take longer, what you'll see is your QRS is going to tend to be wider. Okay, so you're going to see for both of these bundle branch blocks, if you block either side, the signal takes longer to depolarize to the other side. So the QRS will tend to be wider in general when patients have bundle branch block. Now, the other thing to keep in mind is, that signal, it's coming from one side and it's going to the other side. Okay, so normally, right, the signal is going to come down both of these and it's going to go in one direction, right? This signal is going to go to the left side of the heart, this signal is going to go to the right. But in this case, if we block the right side, okay, if we block the right side, then the signal's got to come back around this way. So you actually get the signal kind of going in two directions. So you'll generate an extra deflection, an extra R wave. So that's why we have an RSR wave here. Another way that they write this is the RSR prime. Okay, so the RSR prime. And that's what these so-called rabbit ears represent here. Now, there's a lot of rules and criteria that you can memorize when you're talking about bundle branch blocks, but in general, if you just want to simplify things, what I want you to do is just focus on two spots. Okay, I just want you to focus on lead V1 and lead V6. And the reason I want you to focus on those two is because lead V1 is going to be over here, right? Lead V1 is going to be on one side, and then lead V6 is going to be on the other. Okay, so if you can see these two leads, you can pretty much figure out where these signals are going because you're looking at like the two extremes between these two leads. So that's kind of the way that I remember that. So if I just look at V1 and V6, I can figure out what's happening with these signals. Now, if I focus on V1 and V6 for a right bundle branch block, the classic finding is going to be these rabbit ears, this RSR prime. I'm getting an extra deflection, right? So I have two deflections here because that signal's got to wrap around that second time to get to the right side of the heart. So the biggest finding that I would remember is definitely this M shape, kind of this M shape that we see in V1. That's the most important thing. When you're looking for a right bundle branch block, look for that, look for a widened RSR prime or QRS potentially. And the other thing to look for, if you really want to kind of crack your case here, is this slurring of the S wave that you can sometimes see in lead V6. Okay, so that's all very classic. But in general, like I said, the RSR prime is very classic. And if you're ever going to get right bundle branch questions, usually in step 1 or on step 2, that's what you're looking for. And you can see that represented very clearly here. So you can see this kind of M wave, you can see it in V2, you can see it in V3. But I like to simplify my life here and just say, look, I'm going to look at V1 and really pay attention to this when I'm looking for these bundle branch blocks, because that will really help me identify them. So one thing that I wanted to draw out here is, that's kind of confusing. When you're looking at these leads, this is what your V1 normally looks like. Okay, so you can see that your deflection, your upward deflection here is actually quite low. Okay, but then when you get to V6, you're going to have a lot higher deflection. This is completely normal. This is what a normal EKG looks like in V1, right? So you can see there's a huge downward deflection, very small upward deflection. That's completely normal. You don't have your kind of classic QRS complex in V1. Okay, so when you see these really high R waves, that really is going to call your attention to a bundle branch block, because normal looks something like this. Again, this has to do with the positioning of these leads on the heart and the direction of the current based on where these leads are. Think of them almost like cameras. Okay, so what we call this, when you go from V1 to V6, where you have this really big R wave in V6, really small signal in V1, what we call this is going to be R wave progression. Okay, so a lot of times on an EKG, you'll see, especially when you go on the wards, they'll be talking about, hey, this patient has really good R wave progression. Okay, so they're looking to see the R wave and see if the R wave gets larger, and then you'll also see that a lot of the S wave is going to get smaller. By the time you get to V3, which would be somewhere in the middle here, you'll see something kind of like this. So that's what like a V3 would look like. It's kind of going to be a mixture of this R wave and this S wave here. And then by the time you get to V6, it's going to be pretty dominant R wave. Okay, but in V1, you really don't see high amplitude R waves like you're going to see here in V1 with the patient that has a bundle branch block. Okay, so let's talk about the left bundle branch block. So the left bundle branch block is going to be, again, if we're talking now about blocking the left side of the heart. In these situations, these patients will tend to have a lack of R waves. So it's actually going to be the complete opposite as to what we just talked about. So it's going to look more like your classic V1. The big difference here is going to be this very deep, kind of wide S wave here. Okay, so that's going to be the big difference. And again, that's not super different than, it's a lot more subtle of a finding than the findings that we normally are going to be seeing in V1. And so the way that you really tell what's going on with a left bundle branch block is you look at, again, V6. V6 has this notching in the R wave. That's very classic. Remember, when we get to V6, if we have good R wave progression, we have really big R waves. If we see a notching at the top of that really big R wave, that's going to be very classic for a left bundle branch block. Okay, so we can see with the right bundle branch block in this patient here, we don't see that notching in V6. We actually see a pretty sharp R wave here, but in V1, we have the rabbit ears, right? So again, classic finding, right bundle branch block, look in V1 for the rabbit ears, left bundle branch block, look for the notched R waves in V6. Okay, that's probably, if you had to take two things away from this slide, that's what I want you to remember. The other thing to just kind of add on to this is that you want to kind of remember the things that are going to cause the right bundle and left bundle branch block. Now again, I like to think of the simple, just give me the big three things. So if I had to put this into three categories, I would say ischemic heart disease is definitely in the conversation, right? But anything really that is going to cause right heart strain. So things that might cause right heart strain, for example, it could be a pulmonary embolus, right? A pulmonary embolus would lodge in a pulmonary artery, right? And that would cause a backflow of blood potentially into the right ventricle. That might cause some right ventricular dilation. That might cause conduction abnormalities or delayed conduction into the right side of the heart. So if a patient had a saddle embolus, right, and that was causing some potential hemodynamic compromise, you might see a right bundle branch block. That might be a finding to look for. If a patient has sinus tachycardia and a right bundle branch block and they're short of breath, think about a PE, right? That might be a finding that's pushing you in the direction of a PE. Now, of course, there's other findings like the S1, Q3, T3, and so on, but a right bundle branch block is definitely something that could be given. If a patient has pulmonary hypertension, it's the same thing, right? Think about the pulmonary artery, right, that has hypertension, so there's going to be a backflow of blood. We're going to have blood pooling kind of back in that right ventricle because of that high pressure in the pulmonary artery. That can also cause delayed conduction through these fibers because all that blood's backed up. All this cardiac muscle tissue and gap junctions are going to have a harder time conducting the signal. There might be dilation or damage potentially in this conduction system because of pulmonary hypertension. Okay, so again, anything that causes right heart strain is going to be very classic for causing right bundle branch blocks. Okay, now the other one I just want to help you remember here is if you had a patient that had, like, let's say a patient has an atrial septal defect. Okay, so remember, right, here's my right atrium, here's my left atrium, and we kind of talked about this before. That blood will go from the left, it'll go from high pressure to low. So it's going to go from the left to the right, and then it's going to go through the right atrium to the right ventricle, and then it's going to go through the pulmonary arteries, and it's all eventually going to come back to the left atrium through the pulmonary veins. Okay, so the point is, and some of that blood is going to go to the left ventricle. The point is, though, is that this blood, a lot of it's going to constantly be in this circuit where it's just going to keep returning to the right ventricle. So you might have a dilated right ventricle. So conditions like an atrial septal defect is causing returning blood back to the right ventricle. Okay, so that can also cause a right bundle branch block. The same is true as if you had a ventricular septal defect. Okay, so in a ventricular septal defect, the same concept is true, right? So here's my atria. In this case, there's no problem in the atria, right? I send my blood out to my right ventricle. It goes through my pulmonary arteries, my pulmonary veins to the left atrium, and then it goes into the left ventricle. But the left ventricle has really high pressures, and guess what? There's a little opening here between the left ventricle and the right ventricle. So in a ventricular septal defect, that blood's going to get back to my right ventricle. And again, increased blood in the right ventricle, increased right heart strain, that can also cause a right bundle branch block. So an ASD or VSD or tetralogy of Fallot, pulmonary hypertension, all of these things, just keep them in mind. Understand the pathophysiology of what's happening. Anything that's going to cause right heart strain is going to cause a right bundle branch block. Same is true for the left side of the heart. So if I have anything that causes left heart strain, how about aortic stenosis, right? Less blood is going to get through. Aortic regurgitation, more blood returning to the left side of the heart. Dilated cardiomyopathy, right? What is dilated cardiomyopathy? That's systolic heart failure. I can't pump the blood out of the left ventricle, so it sits there. And then I'm going to have a dilated ventricle, right? Poor cardiac conduction, higher risk for left bundle branch block. Right? And then you can correlate that. If you have a situation where you have a case about a patient that has a low ejection fraction, what finding would you expect to see? Well, look in V6, you'd expect this notched R wave in V6, right? Potentially, because they could probably have a left bundle branch block, secondary to the systolic dysfunction and the pooling of blood, right? So these are all the things you want to consider when you're talking about, when would you see these branch blocks? It's all with heart strain on that side of the heart.